we need to push as hard as we can to get our babies out, and that you have to be on your back with your legs fully back, and once you're 10 centimeters, you have to like do this directed pushing thing. And you could totally do that, and there's nothing wrong with that if that's what you want to do. What matters though is that every single parent understands fully what their options are, what the risks, benefits, and alternatives to those options are, so that they can make their own informed choices around pushing, because that matters, and that will help your experience be so much more positive. There are some places where providers routinely will practice one way, will offer more of an individualized approach where they're supporting you in making your own choices, covering the information with you. And there are other situations and other places where providers just want to do the thing they want to do. I have one of my coaching clients who told me recently that her provider, she took her birth plan that I made with her to show her provider, and her provider said, "You want to birth in a different position other than your back?" And she was like, "Yep." And he was like, "No, I'm not okay with that. We're going to force you on your back." And she was like, "No, you won't. And I'm going to find a new provider." And she did. So, we can come across a provider that really isn't practicing in an evidence-based way, that really isn't giving you a lot of support. Other times we find providers that are great and give you lots of options and lots of support, right? So it's just important ultimately at the end of the day, since we really don't know exactly how someone will treat us in labor. If there's a rotation of providers and you don't know which one you're going to get, that's even more important then to just do this independent education yourself. And to also understand the communication tools and the advocacy tools so you can protect any of the choices that you make. I have quite a few moms who I do that initial breakthrough session with, and we'll have a conversation about like what they know, what they don't know, and map out that plan. Yeah, so I'll like talk to those moms and they might be like, "Yeah, I know that laboring down is beneficial. I know that provider hands off and warm compress and all these things protect my perineum." And then I'm like, "Okay, cool. Can we advocate for that though?" And they're like, "No, I have no idea how to do that." So reducing the risk for tearing, having a smooth and empowering pushing phase is not just about understanding what your options are. It's also about understanding how to apply those options. And that's where personalized coaching can be really supportive, because I can give you general information. But when we know your provider situation, how your provider responds to different questions that I'll have you ask them, then we can understand what your risks are around certain things with that person, with that establishment, and how we can create a customized plan for advocacy that can really protect what your choices are. So without further ado, let's get into laboring down. So what is laboring down? Laboring down is also known as delayed pushing, passive descent, or rest and descend, meaning we're waiting after complete dilation before actively pushing. So during that waiting period, contractions continue to move the baby lower and lower into the pelvis. So this practice is most often discussed with people with epidurals because they may not immediately feel that strong urge to push. This can be something that you do in an unmedicated birth as well. So one time I supported someone many years ago through birth as a doula, and she was 10 centimeters at a home birth, unmedicated. And she was like, "I don't feel the urge to push." Most of the time, like overwhelmingly most of the time, in an unmedicated birth, you will feel the urge to push, because as your baby descends into the vaginal canal, if this is the back of the vaginal wall, when baby descends, they put pressure on pressure points that stimulates this urge to push. There's the Ferguson reflex and the fetal ejection reflex, and both of those reflexes work together to cause your brain to release spurts of more oxytocin, so your contractions get closer together, and to give you that urge to push. And it takes you to the point where your body is like pushing. It's something that your body just does, and it's one of the best parts about birth, honestly, from my opinion. It's a very, very cool part. Pushing is very cool. Every once in a while, though, someone might not get that reflex. This is very rare, but it can happen. And in that situation with this one mama, we waited for a little bit. We waited like an hour or two. And eventually we were like, "Okay, we waited. You're still not really getting the urge to push. So maybe we'll give you some gentle guidance." And we gave her some guidance. And she did have to work a little harder to get her baby out, but she did. And she also did it without tearing, which was really incredible. But what mattered was that we didn't say, "Oh, we checked you. You're 10, you're open enough. Now we're going to just tell you get on your back and pull your legs back and push as hard as you can." Instead, we took an individualized approach, which means, how is this mom doing? How is the baby doing? Are vitals okay? Has the water been broken for a long time? Is there some concern about infection? Are there signs of infection? And I'm not a care provider, but these are just some questions that you can ask, questions that this mom was educated enough to ask to help inform her around what decision she wanted to make going forward. And so she understood I could do directed pushing. I could try to gently push. I could just wait. She chose to wait. Most of the time, when we choose to wait, baby will get a little lower because our uterus continues to push baby down. Baby will get lower, and then you might probably get the reflex or feel more pressure, and then you can start pushing then. She just really wasn't getting that feeling. This is very, very rare, but this was because of a positioning issue with her baby. Her baby was in a position where they weren't putting the same kind of pressure on the back of the vaginal wall that a baby normally does. And so that pressure reflex wasn't getting stimulated. And that's why. So we did a little bit of gentle guidance, guiding her to be in whatever position that felt most comfortable for her, trying different upright positions, taking a big deep breath, and with the contraction, just engaging her tummy muscles and pushing down, not with your pelvic floor. It's relaxing your pelvic floor, but engaging your diaphragm and your tummy muscles and pushing down. So that's something that we tried with her. And eventually we got the baby low enough to the point where she was able to kind of feel more pressure and get a little bit of the reflex and get her baby out. And it was very cool. So that is just a story to illustrate how not everyone experiences the fetal ejection reflex. Sometimes there are good reasons to wait, and sometimes there are good reasons to try to push a baby out quickly, And so ultimately what matters is that we take an individualized approach. And that's why this mom, we had a positioning hiccup where we needed to intervene a little bit, which is some gentle guidance, and that worked really well for her. And the reason why we had a positioning hiccup, but then things worked out so well, is because we took an individualized approach, that mom considered her preferences, how she was doing, how her baby was doing, and then it made an informed choice from that point. Next, I want to talk a little bit about what laboring down looks like with an epidural. So most of the research we have is with laboring down with an epidural specifically. We don't have very much on unmedicated births. That's because most of the time, unmedicated births, you get the fetal ejection reflex. So laboring down isn't something that happens as often. And I also wanted to say that with unmedicated births, it depends on how many cervical exams you're getting, but let's say with my first birth, that one, I didn't really get many cervical exams at all during the labor, just one in the middle. And at one point, I remember feeling oh, I feel pressure. Is this me wanting to push? And this is when I got the exam and she checked me and she said, no, you're 5. And I was like, okay, that's not me needing to push yet. I just didn't know what the reflex felt like. I knew in my head, but not really in my body. But then when the baby got down lower and I started to spontaneously push, I was like, oh, there's the reflex. It's very possible I could have been 10 centimeters for a little while before that reflex kicked in, but we just don't know what my cervix was doing because we weren't checking my cervix every 10 minutes, and the cervix can change so quickly. Someone could check you, you could be 7, and then you can be in 10, 5 minutes later. That does happen. So if we're not doing constant checks, which is good, it's more evidence-based to checks on an individualized approach, but trying to space them out every few hours because you don't want to increase the risk for infection if the water bag's broken. But ultimately, if we were checking everyone frequently and really monitoring the cervix, I wonder if we would find that some people do in an unmedicated birth get to 10 and then they don't get the reflex for a little bit. Who knows? It's just interesting, with an epidural, we're just checking more frequently often and moms aren't getting the same kind of reflex. And so that's why the studies and laboring down typically applies to the epidural more frequently, because that's a choice that is one that is something that moms can consider with epidurals and is rarely something that's even a conversation when you're doing an unmedicated birth, because most of the time you will get the reflex when your body is ready. Anyway, let's move into station a little bit. I'm going to go deeper into epidurals and more about what this looks like later, but I kind of want to give you a little bit of a framework and understanding around how baby moves through the pelvis and what that looks like for laboring down specifically. So with station, baby goes through -5 or -3 to +5 or +3. And there isn't any set, we do it this way, we do it that way. I've seen -5 to +5. I've seen -3 to +3. I teach -3 to +3. So that's what we're going to talk about today. -3 means that your baby is floating above your pelvis like this. Then baby will just start to descend into your pelvis, right? So they go down, 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 and then they're at -2, and then they're at -1. And then once your baby hits the ischial spines, which means that the top of your baby's head has reached these bony structures. So if you're sitting right now, wiggle your booty back and forth. You feel those bones you're sitting on. Those are your sits bones or the ischial spines. Once the baby's head has reached the ischial spines, that means that your baby is at a 0 station. And then after 0 station, the baby will descend more, they'll rotate, and then they'll come all the way to +3, which means they're about to crown or about to come out. So this is important when we're talking about laboring down. We want to know what your baby's station is. I think that's a really good piece of information to consider if you're thinking about doing laboring down. Where is my baby in my pelvis? Is my baby up high? Are they really, really low? So there is not a universally accepted cutoff, but many clinicians would feel more comfortable starting active pushing when the baby is 0 station or lower, especially if there's an epidural and no strong urge to push. So with an epidural, you won't feel if the epidural is working well. Every once in a while, they don't work as well as we plan, but most of the time they do. If your epidural is working well, you won't be feeling probably in your belly or your legs. So you won't be feeling the contractions, but most of the time you will be feeling pressure. So sometimes someone can check you with an epidural and say, oh, you're 10 centimeters dilated. And it's like, okay, cool, but I feel nothing. I don't feel any pressure. Maybe then in that situation, we could say, well, where's your baby? Oh, your baby's like -1. So, it's kind of rare for you to be 10 centimeters and -1, but it can happen. Your baby's still kind of up high, or your baby's like right at 0. So like we could start pushing, but they're not like, super, super low. Like they could be lower. That's just like a conversation to have. Okay, maybe I just want to see if my baby gets like 1 station lower. Maybe then I'll feel like the urge to push. Maybe we can wait and see if baby can just get a little lower on their own, right? That's kind of what a laboring down conversation could look like. Let's talk a little bit about what the research has to say. So I have 3 studies I'm going to share with you. In 2018, the JAMA trial was a large randomized controlled trial published in 2018 involving first-time moms with epidurals. Like I said, most of this research is about people with epidurals. We do have one recent study that came out that had most people with epidural, but some people not. So I'll talk about that one soon. So the researchers compared immediate pushing at complete dilation and delayed pushing, meaning waiting 1 hour before pushing. The results surprised many clinicians. They found that delayed pushing did not increase in spontaneous vaginal birth rate. So that means if we wait for your body to bring the baby down lower, do laboring down, it didn't really impact your cesarean risk. That's what they found in this study. Other studies have found something a little bit different, but I want to kind of share the 3 main ones with you. Delayed pushing led to a longer total second stage of labor. The second stage of labor means that your cervix is 10 centimeters dilated. You could be pushing or not pushing. It doesn't matter. Once your cervix is 10 centimeters dilated, you're officially in the second stage. So if we do laboring down, the second stage is longer, which makes sense. Immediate pushing was associated with lower rates of postpartum hemorrhage and infection. So they found that you're a little more likely to have postpartum hemorrhage or get an infection if you do the laboring down. In this study, they found that. Immediate pushing resulted in a shorter time from complete dilation to birth, which also makes sense. So that's one study. Next was the Cochrane Review. So the Cochrane Review analyzed 13 trials involving nearly 2,900 people with epidurals in 2017. Researchers found that delayed pushing increased the likelihood of a spontaneous vaginal birth. So this one was a little bit different. This study found that if you do laboring down, you have a slightly lower chance of having a cesarean. Also, it found that there was a reduced amount of time of active pushing, which makes sense. So instead of I'll say it this way, if we choose to do laboring down, which means we're just going to wait until your body starts to spontaneously bring your baby lower and lower through contractions, and your baby just naturally gets slower. And then you say, okay, now I'm going to actively push, right? The time you're actively pushing is reduced. So the benefit here is that it can reduce exhaustion for you because we're not having you actively push for a really long time. Instead, you're only actively pushing for a shorter amount of time. The potential downsides were they saw an increase in overall length of the second stage, same as the other study. So that means that from the time your cervix is open to the time baby is born was longer. And it said that it did not clearly improve any major maternal or neonatal outcomes. So they weren't seeing saying that outcomes were significantly improved. Only like exhaustion could potentially be reduced. C-section risk could potentially be reduced, but there wasn't any significant like big difference in outcomes for mothers and babies. So the authors concluded that the evidence was not strong enough to recommend one approach for everyone, and that patient preference and clinical circumstances should guide decisions. So this is an individualized approach, kind of like what I was talking about before. So the next study was published in the American Journal of Obstetrics and Gynecology, or AJOG, titled Active Second Stage Duration Under 15 Minutes in Spontaneous Vaginal Deliveries with Delayed Pushing. So Dr. Ela Montfort and her colleagues in the research evaluated labor management outcomes at a university hospital in France. And so one thing that they found was the active pushing time was very different. So this is the more recent study that kind of went viral on Instagram. So if you've heard of laboring down from Instagram in the past few months, probably it was about this. The study revealed that under a protocol of laboring down, which is delayed pushing, the overall average duration of active maternal expulsive efforts, means the time that you're like, right, the time you're actively pushing, remained under 15 minutes, you guys. Anyway, mic drop. Across the entire cohort of 10,565 spontaneous vaginal deliveries, which means spontaneous vaginal delivery means they were birthed spontaneously and not by C-section, the overall mean duration of active pushing was just 8.8 minutes. For first-time mothers, the average active pushing time was roughly 14 minutes. The protocol. So the hospital standard clinical policy allowed for everyone to rest and passively labor down for up to 3 hours after reaching full cervical dilation, or 10 centimeters, before they were starting to actively push, allowing the baby to descend naturally. 82% of the women in the study had an epidural. Even with a dense regional block, waiting for the physiological urge to push resulted in highly efficient active stages. So what that basically means is, like, even if you got an epidural, which most of these people did, they found that if you just waited for the mom to feel pressure and feel like, oh, I think I need to push, I feel pressure, it kind of feels like I have to poop. Even with an epidural, you'll probably feel like you have to poop. That's very common. Not everyone feels that way, but that's like a common. If we waited, then the time that you're spending actually pushing, right, is significantly reduced. I mean, people push for hours and hours and hours in the US. So the fact that these people were pushing for around 15 minutes is just remarkable. The researchers noted reassuring maternal and neonatal health profiles, including a low rate of immediate postpartum hemorrhage, which is 5.1%, which is good, and an exceptionally low incidence of severe perineal tears, which is 0.5, which is like, what? Like, that's very low. It's like shocking to me. So that is a summary of some of the research that we have on laboring down. So next, let's talk about why different organizations disagree on recommending laboring down. So first, let's talk about the Association of Women's Health, Obstetric and Neonatal Nurses, or AWON, and the World Health Organization. They generally support laboring down or delayed pushing to conserve energy and support physiologic birth. The Royal College of Midwives, or RCM, supports the practice of laboring down, particularly for women using epidurals, provided maternal and fetal conditions remain reassuring. The National Institute for Health and Care Excellence, or NICE, they also recommend laboring down. So before we talk more about what ACOG says, I do just want to be clear that there's a big difference between laboring down and labor arrest. So I'm going to go into what ACOG says, specifically illustrating labor arrest. So I just want to be clear, laboring down simply means that someone is choosing to delay pushing. Labor arrest, or a prolonged pushing phase, means that perhaps there's some kind of positioning issue, and that can happen with or without laboring down. So labor arrest or any kind of like problem does not mean that laboring down is always like connected, if that makes sense. So here's what ACOG says. In early 2024, the American Congress of Obstetricians and Gynecologists, also known as ACOG, released recommendations about managing labor and managing labor arrest. They define prolonged second stage of labor as more than 3 hours of pushing in someone who's giving birth for the first time and more than 2 hours of pushing in someone who's given birth before. ACOG recommends an individualized approach rather than a one-size-all definition, which which is great. So they say that an individual diagnosis of labor arrest should take into consideration several factors, including the patient's preferences for labor and birth, their labor progress factors in the birth setting that impact the likelihood of being able to give birth vaginally, the risks and benefits of available interventions. So this is great. So ACOG is saying like we should take an individualized approach and consider all these factors rather than saying, oh, officially it's been 3 hours, time for a C-section, right? ACOG also currently recommends that patients begin pushing when the cervix is fully dilated rather than delayed pushing, which is also known as laboring down. So ACOG does not recommend delayed pushing or laboring down if you have an epidural. So that's what ACOG has to say. Next, let's talk about what NICE has to say. So in the United Kingdom is where NICE is. They provide clinical practical guidelines for healthcare workers in the UK. They divide the second stage, which is, right, your cervix is 10 centimeters dilated. They divide it into 2 phases, actually, the passive and the active, which makes sense. So there's the passive, you're 10 centimeters, we're like waiting, you're not quite pushing it. And then there's the active phase where you're going, right, and you're pushing. The passive phase begins with the cervix is fully dilated. And with the passive phase, it may take up to 2 hours where someone has an epidural, especially, and they're giving birth for the first time. And they may labor down for several hours after full dilation before they even begin pushing. That's what NICE says. Someone who has given birth before might wait up to 1 hour before pushing if they have an epidural and they're fully dilated. In contrast to ACOG, NICE recommends laboring down based on evidence that it might lower the risk for an unplanned cesarean. It lowers the risk of needing forceps or vacuum in those who have given birth before, and it shortens the length of the active phase. The active phase begins right when the baby is visible or when the cervix is fully dilated and pushing has started. NICE identifies the abnormals and states that a delay in the second stage of labor is defined as more than 3 hours of pushing in the active phase if you're giving birth for the first time and more than 2 hours of actively pushing if you've given birth before. So in summary, ACOG currently recommends beginning pushing once full dilation is reached. Their guidelines cite evidence that delayed pushing prolongs the second stage and does not appear to provide enough benefit to outweigh the longer labor. NICE remains more supportive of laboring down, particularly for people with epidurals. Their interpretation of the evidence places greater emphasis on reduced active pushing effort, potential reductions in operative birth, right, isn't having a cesarean, allowing fetal descent before maternal pushing begins. And so this is why you can see some different recommendations internationally. What appears most supportive by the evidence today, if we had to summarize all the research in just a few points, number 1, laboring down usually shortens active pushing. So the time where you're going, that time is shortened if you choose laboring down, which may help to decrease your risk for exhaustion. People who labor down generally spend less time actively pushing before the baby descends, before pushing starts, if that makes sense. Laboring down usually lengthens the overall second stage. So that means by the time your cervix is open, if you choose laboring down, even though your active pushing is shorter, the time from 10 centimeters to baby being born is longer. Although pushing time may be shorter, the total time from complete dilation to birth is typically longer. It does not appear to dramatically change cesarean rates. The best modern evidence has not shown a major reduction in cesarean births from laboring down. So some studies have found that it reduced it a little bit. Other studies didn't really find a big difference. So we don't really have any concrete, like universal, like, okay, for sure, we are really seeing this consistently, right? Also, the baby's station really matters. So many clinicians now believe that the baby's position and the station at complete dilation are more important than just a blanket push immediately and like always labor down kind of approach. And I 100% agree with that. This is going back to that individualized approach. Like what's going on with your baby? I think honestly, you guys, like in any situation where we're like, what do we do when it comes to like trying to resolve a positioning issue? We think your labor has stalled. We're wanting to induce you. We're like wondering if we should labor down or not. Like all of those choices and different like scenarios really come back to like, what information can we get about the baby's position? That's huge. If you want to do an induction, okay, cool. Like, let's see what your baby is doing. Is your baby low? Are they well applied to the cervix? If not, if we get medication that's going to cause contractions and your baby's in your pelvis, like leaning to one side, it's just going to force your baby into your pelvis in kind of a funky position. So maybe that's not the best choice. And maybe we should fix that first. If you're in labor and we're kind of worried about some kind of positioning issue, maybe you have a lot of pain in your back. Maybe your labor is stalling out. What's going on with your baby? Oh, is your baby stuck at the ischial spines, which I showed you before? This is called a deep transverse arrest. The ischial spines is the most narrow path that baby has to go through. Like in the pelvis, they have like this length that they have to descend through, but here it's shorter. And so basically, sometimes babies can get a little stuck there. Is your baby's head extended? Is the head tilted to the side? If we understand what's going on, which we could do through a cervical exam, then we know how to resolve that. And so that's really like one of the best forms of information we can get from a cervical exam. Dilation's like, I don't know, but baby's position, where they are and their station is huge. It's really huge. And this is something that in my coaching program, I teach all my moms like what that looks like in many different scenarios, how to fix it. If ever you're in labor and they're like deep transverse arrest or baby's posterior and having a hard time rotating, there's something that you do for each one of those things that can fix it sometimes. Yeah. So anyway, if baby is still high, waiting might allow an additional descent. And if your baby is already low and the parent feels pressure, then immediate pushing might make sense, right? So it's kind of like, well, how are you feeling? If you're 10 centimeters dilated, like, do you feel pressure? No? Okay. Like maybe laboring down is a conversation that we can have. So this individualized approach is reflected in current ACOG guidelines. Unfortunately, not every provider is going to follow ACOG guidelines, and some providers really do religiously. It just depends on your provider. One example is like, we're going to encourage everyone to get an induction if their baby measures big, even though ACOG doesn't say that that's something that we should do. So, providers will do their own thing. Some providers might also be like, I never support laboring down, in which case, you could say, well, ACOG supports it. No, ACOG doesn't support it. You could say like, well, NICE supports it. These other organizations support it. And this is something that I want to try. If you want to, it just kind of depends on the provider. I also want to say that the urge to push matters. So this physiologic urge to push often corresponds with fetal descent, which makes sense. Like if you feel pressure and you feel like you want to push, it's probably because your baby is really low. And many midwives and physiologic birth researchers argue that waiting for a strong spontaneous urge may improve maternal comfort and efficiency, although the evidence remains incomplete. So we don't really have enough research on this, on like the outcomes essentially. And it's something that we just need to study a little bit more. Okay, well, now I want to talk a little bit about the second stage of labor. I want to go kind of deeper into that and what that kind of looks like. I use that term, the second stage, I defined it. But I think it's important for you to understand a little bit better, because one of those risks to laboring down we found is that it does increase the second stage. And why is that something that we have to think about? So the second stage, like I said before, begins when the cervix is fully dilated. So it's open. Yeah, and longer second stages are linked with a higher risk for maternal infection, a higher risk for having a severe tear of the perineum, a higher risk of postpartum hemorrhage, and a higher risk of postpartum fever, a higher risk of needing forceps, vacuum, or cesarean. But it's kind of interesting to see that's just like well-known, like risks that are associated with the second stage being longer. But at the same time, we found in that recent study in 2025 that the laboring down actually had a really, really low rate of postpartum hemorrhage. So it wasn't like anything abnormal, an extremely low rate of perineal tear. And so it says here that like a longer postpartum, or like not postpartum, a longer second stage increases the likelihood for tearing. But with laboring down in that recent study, we found that it actually makes tearing rate really, really low. So we need more research. And I also just want to like go over this just to clarify to you. There are reasons why the second stage can be really long sometimes. That means that maybe there are other complications happening, like positioning issues that can increase the risk for tearing, for example, right? So sometimes like someone might have a really long, like a 3 or more hour second stage not because they're laboring down and that's just what their body is doing, but because for that person, the baby is maybe facing forward or posterior, which sometimes is totally fine. Other times it can make labor longer. It can increase the risk for tearing. So that's just kind of like something to be aware of too. Also, birthing positions can really impact the length of the second stage if you have an epidural. So having a doula, a nurse or midwife, or someone who's skilled in helping patients with epidurals find the right position is really huge. So if someone has like a really long pushing stage, I get these like quite often in my calls. Someone will say like, oh, with my past birth, I was pushing for like 3 hours and then I had a C-section. And I'm like, oh, were you on your back the whole time? And they're like, yeah. Oh, okay. Like maybe if we moved, you wouldn't have had a C-section, but also maybe you would have too. Like we can never know, unfortunately, if something was going to fix it or not. I've also been to births where there was a positioning hiccup and earlier in my doula years, and we did everything we could and still a C-section was needed. And maybe that's the way that that baby needed to come into the world. But we also know that moving in labor and pushing decreases pain and decreases pushing time. In my coaching program, I have a formula for what to do with an epidural specifically and without an epidural if the pushing stage is long. And I would say like an hour. Like once you've been actively pushing for an hour, then we want to get into these many different positions. And I just had a mom recently avoid an episiotomy and a cesarean. Both of those things she was like under threat of during her pushing, and she was like, nope, nope, nope. Instead, I'm going to do this. And her baby ended up rotating to be posterior, so the pushing was a little bit longer. She did the formula, and then she texted me, and she was like, by the way, my baby flipped OP, and I got him out vaginally without the episiotomy and without having a C-section because we did the formula, and it worked, which was really awesome. So that's available. If you're in my coaching program, you can access it. Yeah, and I also wanted to share that epidurals can potentially slow the pushing phase too. So researchers have suggested that epidurals could potentially decrease your pushing efforts by reducing the effectiveness or strength of uterine contractions. And so this is because epidurals numb or decrease the feelings of nerves on your cervix and pelvic tissues. So normally as your baby's head descends and puts pressure on the cervix, there are nerve endings that send messages back to your pituitary gland in your brain. And this stimulates your pituitary gland to produce more oxytocin, which is the hormone that strengthens your contractions. So this is called the utero-pituitary reflex. It's very cool. And so it's thought that the epidural can interrupt the utero-pituitary reflex, which makes sense. And this is one of the reasons why laboring down is an option that people with epidurals are more often likely to consider, because rarely is laboring down something that is needed in a normal physiologic birth because things keep moving. Epidurals might also be relaxing the muscles of the pelvic floor, which could affect the baby as it's rotating and coming through the pelvis. So if that theory is correct, that means that epidurals can weaken your contractions. It's likely that the response relationship between the concentration of the local anesthetic and the epidural and the effects on the second stage of labor is something to be aware of. So basically, the more medication we get, the weaker your contractions because of that interference with the normal reflex. So if you do have an epidural, what I wanted to share is that there are different options that you can explore when it comes to the pushing phase. So some moms want to have a normal physiologic birth, and then they end up saying, actually, an epidural is the right choice for me, which is totally okay. But what can happen sometimes is we choose to get the epidural and then we forget that you have options. It's now I just have to lie on my back and I have to do it. I'm told, and that's not true. You can use an epidural in the way that feels best for you. This is your birth and this is your body. You can say, give me the lowest dose possible. I want a really small dose. I still want to feel a little bit, but I just want to take as much of the edge off as I can. If you're in that place, IV opioids might be a good option to consider too, but you can't do IV opioids when you're getting close to pushing, because IV opioids will get more of the medicine will get to your baby, and that can cause respiratory depression and increase their likelihood of needing resuscitation. But getting IV opioids a little bit earlier in labor is something that you can consider if you need help getting through a hard moment. But back to the epidural, you could ask for a low dose. You could also get the epidural, and then you can say, turn the epidural off. And there are differing medicines in epidurals. And we do have some research. Evidence-Based Birth came out with a great article quite a while ago and video on YouTube, and it's the effects of epidurals in the second stage of labor. And they talk about some research where they gave some people, it was saline in their epidural, and the other people they gave the epidural medication when they were in the second stage to see if it affected their pushing at all. And they found that it didn't change it in either groups because the medicine was still in their system. So they still were having that, like, they still weren't getting the fetal ejection reflex or anything like that because it still was in their system. But there are other medications that are used in epidurals that might wear off a little sooner than others. So it just really depends on the medication that's being used. This is something you can always talk to your providers about if you want. But in some cases, you can turn the epidural off and then you can see if you get a little more feeling if you want when you're in the second stage. So that is also a way if you wanted to labor down, but potentially you wanted to be able to have more feeling maybe sooner than later. Potentially turning off the epidural could give that to you, but it really just depends on the medicine that was in there and how long that stays in your system. So this isn't like a proven way at all to like give you the reflex faster or like make laboring down go faster, but it is just like food for thought and something to think about. Just inviting all of you to remember that you have agency and you can play around with your tools and use them to best support you. If you do have an epidural too during pushing, I will say actually this, epidural or no epidural, doing pushing, move frequently. Because when your baby's coming through, we want to help open up the pelvis to give them the wiggle room that they need to kind of like wiggle their way through. So moving positions frequently is great. If you're tired, push on your side. If you have more energy, maybe try hands and knees, standing. Squatting and sitting on the toilet, all of those positions are great. Sitting and squatting does increase the risk for tearing. So hands and knees, standing and side lying are the best for reducing the risk for tearing. If you have an epidural, you can push in side lying, you can push in squatting and in hands and knees. If you don't have an epidural, you can push wherever you want. If you are in a situation, epidural or no epidural, where you say, okay, I'm 10 centimeters and I'm not really getting the urge to push. Maybe baby's like -1, and we're like, maybe I kind of want to wait a little bit and see if they could get to like +1 or like a little bit lower, maybe see if I get the urge to push. I want to try some laboring down. Maybe it'd be good for you to, if you're exhausted, maybe first rest. Think about that. If you're like so exhausted, rest on your side with your leg up on a peanut ball for a little bit. But if you have the energy, try to get gravity on your side because gravity can help bring your baby down. So squatting with an epidural would be great. Hands and knees. You can do hands and knees where you're instead of like kind of flat back hands and knees, you can be a little more upright. You can get like a birth ball on the hospital bed. If you have an epidural, I think that would be best. So you're kind of a little more upright hands and knees. If you are anywhere else, hospital, home birth center, having an unmedicated birth, go sit on the toilet. That's a great place to be because we have this natural pelvic floor release response when we're on the toilet. So when you sit there, your pelvic floor muscles just relax and that allows your baby to descend. And that's a really great tool. It's called the dilation station, but even if you're fully dilated and baby's still a little high, I think the toilet is a really great place to be. And just try to change positions frequently. What is it called? Asymmetry. Asymmetry is a really great tool to use during pushing or during laboring down, which just means we're going to open the pelvis in different ways. So maybe I'm going to be in hands and knees with my legs kind of neutral, and then I'm going to lift one leg into a lunge and just have a couple contractions like that, and another leg into a lunge. If you're sitting on the toilet, you could get a yoga block. Highly recommend you bring a yoga block to the hospital or birth center or have one at your home. Just put a yoga block under one leg or a squatty potty with like one foot up, So now we just took the pelvis from here and kind of brought it to here and then put on the other leg, brought it from here to here. So we're opening up the pelvis a little bit to create more space for the baby to be able to descend and move through. A neutral pelvis is a little bit harder for baby to navigate, but moving frequently really supports optimizing, right? The space that baby needs to be able to go through. That is all my information that I have for you today. This was really fun. You can book a call. It's a free birth breakthrough session. So we'll together kind of map out a plan needed for you to feel confident and prepared for birth and also explore if my coaching program would be a good fit for you.